And particularly, I want to thank you for acknowledging all of the sponsors of this event, because I haven't met them personally, but I'm very appreciative of the resources that go into bringing someone to do this sort of work with you. It's been a great pleasure to work with you and your colleagues. I've enjoyed having the opportunity to get to know people here, particularly in the Prevention Research Center and the Department of Family Medicine and Community Health. Elaine Borowski, my able assistant here, is director of the Prevention Research Center, and I've had splendid opportunities to meet her and to meet her students and colleagues, several of whom have made themselves available to get me through various phases of this visit. Sue, who just introduced me, had the dubious responsibility of meeting me at the airport, for which I'm largely grateful, because I no longer have, well, I should say I now have the worst assistant of my career, myself. I'm allegedly retired, but I'm somewhere between pseudo-retirement and quasi-retirement, striving to get to semi-retirement, and mostly unsuccessfully. But thank you, Sue, and your colleagues, Darcy Friedman, Erica Trappel, with whom the senior staff in the Prevention Research Center, with whom I've had the most opportunity to work over the last 2 days. And just a brief story about the tie. It is legend that Kurt Stange approached his boss one day and said, "What a lovely tie." And he immediately ripped it off his shirt and handed it to Kurt, and it's been hanging on the back of Kurt's door for emergency purposes ever since. And I saw it, and I was desperate for a tie. In fact, Elaine and Darcy and Erica and Sue all volunteered to ask their husbands and bring a tie. Darcy actually brought one, but thank you for the loan of the tie. Well, you obviously have a splendid opportunity in this particular city, in this particular time, because of convergence of historical circumstances and talent that offer the nation some guidance on how to deal with some of our most compelling issues in public health. And the fact that the whole city has been declared a food desert because of the paucity of food markets makes your experience in tackling the issues of food access in this city, and more particularly healthful food access, is going to be instrumental in our attempts to quell the obesity epidemic. I want to speak today about this big problem that we've acknowledged nationally for now nearly a decade. It took us a long time to get there, but we have come to an appreciation that we have a very real problem of getting all of the research that we've produced into practice. Congress recognized this a long time ago because they were spending billions, mostly going to NIH, and they kept asking NIH, where's the evidence that this is being applied, that all of this research funding is going to work? I think my answer to the question is that most of the research has missed the mark of what practitioners and policymakers need. Hence my suggested remedy that if we want more evidence-based practice, we need more practice-based evidence. So here's the problem as it plays out in one scenario with policymakers and researchers. Where am I? You're 30 meters above the ground in a balloon. You must be a researcher. Yes, how did you know? Because what you told me is absolutely correct, but completely useless. You must be a policymaker. Yeah, how did you know? Because you don't know where you are, you don't know where you're going, and now you're blaming me. So these are the perspectives we bring to the table. You know, you guys are dumb because you're not using our research. And on the other side of the table, you guys haven't given us any research we can use. Or it's not actionable in many situations. So we have two big challenges. Closing the gap between the evidence for implementation that policymakers, program planners, practitioners, and communities need and what they're getting from our research. And the second challenge, reforming some of our peer review and editorial tendencies that have had a way of locking us into the pattern that we're in. And it's easy to point the finger, as I often do, at NIH, because it's the gorilla in the room on research funding. But NIH has been very devoted to peer review, and peer review is us. So we have nobody to blame but ourselves in the end if we don't reform the peer review process that has got us locked into this pattern. And then there are the editorial tendencies driven in part by the publishers of the journals that the editors serve. And I'll touch on some of those editorial tendencies and ways in which they might be reformed to help facilitate us closing this gap. The two biggest opportunities then are extending participatory research principles. And I don't mean to make this too precious with community-based participatory research. I mean participatory research in the broader sense of engaging practitioners and policymakers and program planners in our research formulation so that we are assured from the beginning that we're addressing questions of importance to them, not merely ones that will advance us a small notch on the theoretical trajectory. But extending participatory research to these others in the use of natural experiments that they're engaged in continuously with the passage of policies, the planning of programs, the implementation of programs, the dissemination and the scaling up of programs. Each of those is a natural experiment. And so we need to pay attention to the surveillance systems that we have in place that provide us the opportunity to do natural experiments which may emerge too quickly to be pursued with a grant from NIH. And so having surveillance systems that provide us with baseline data and multiple baselines over time is our best hope of being able to answer the questions about what's working and what's not working. Evaluation of the programs. We need to make a commitment every time we acknowledge that we're planning a program for which we don't have certain evidence that it will work. We're combining a variety of interventions, each of which has some evidence. Much of the evidence is not particular to our community or population. And so we need a commitment to evaluation of our work. We need to think of ourselves as experimenting practitioners. That is, every program we plan should be seen as an experiment on which we're going to learn whether and with whom it works or doesn't work. Continuous quality improvement methods that have been honed so well now in some healthcare settings, thanks to people like Kurt Stange and his colleagues with practice-based research networks. And finally, I think we need to combine participatory research with multi-site randomized controlled trials so that we expand the external validity of the findings from the trials. So many of the trials are conducted under hothouse conditions, academically controlled, so that they're not representative of any other setting, much less even the setting in which they're conducted, if they are done with such controls. And so we need multi-site controlled trials to lend us the internal validity of randomization and control with the external validity of multi-sites and settings and circumstances. All right, so here's the phrase that is most often uttered to describe this problem. It takes 17 years to turn 14% of original, and implicit here is applied research, to the benefit of patient care. This comes from a review of multiple reviews done in the early 2000s, so it's a little out of date probably, but I dare say we haven't accelerated the application much. It was also done with studies in clinical settings, and so generalizing this to public health and community settings may be a little hazardous, but I don't see any reason to believe that we're more effective in those venues. So this is the 100% of original research and the 14% of it that's getting implemented. We lose some 18% of the original research because it's never submitted for publication. And the reason it's never submitted is that most investigators are disappointed with negative results, and or they believe that negative results will not be so acceptable to journals, and they're right. There is a systematic bias toward publishing positive results when faced with a choice between two manuscripts. But negative results, as most of you who have worked in practice settings know, is just as valuable as positive results, telling you what probably won't work in your setting, although you might be able to make it work. 46% of those that are submitted, the manuscripts submitted, are accepted. And the reason for that loss of manuscripts never published is that they either are viewed as too qualitative and not quantitative enough, or there are design issues, threats to internal validity in particular. Most of what gets accepted gets published, because after the editor has gone to all the work to process these manuscripts, they're going to be sure that it gets published. But we lose another 35% from publication to getting cataloged in the bibliographic databases that people use, like Medline, PubMed, and so forth, that people use to consult the research, the body of research available. Lack of numbers and design issues is also the culprits in much of that loss. And then we lose another 50% because of inconsistent indexing that results in a lot of the things in the bibliographic databases not being seen as worthy of inclusion in the systematic reviews that lead to the guidelines and the textbooks that practitioners depend upon for implementation. Notice in this last link between reviews and implementation that there's no real loss there, and that might just be an artifact of the methodology here, but it will be significant to note the time lags between these. About a half a year between submission and acceptance, about another half year between acceptance and publication, about a third of a year between publication and bibliographic cataloging, 6 to 13 years between cataloging the studies and getting around to the systematic reviews that lead to guidelines and textbook publication of the reviews. About 9.3 years on average between that which gets into textbooks and guidelines and its implementation and practice on average. Now let's look at the pipeline through which this evidence has to pass in order to reach the potential practitioners. The pipeline is a metaphor that's used very commonly by the scientific community. It's used officially by NIH, and we all think of it in this way to some degree. So we're going to talk about this 17-year odyssey, from priorities for research funding to peer review of grants, which begins to squeeze the things submitted for publication, for research grants, publication priorities and peer review, which squeezes it further, research synthesis, which squeezes it further. A lot of things don't qualify under the rules of many of the systematic review procedures, like Cochrane Collaboration and the Task Force on Community Preventive Services. And then guidelines for evidence-based practice, and finally out the other end comes this trickle of evidence. And it seldom has taken much into consideration the funding limitations of practitioners, the client or population needs and demands. Needs may be considered, but demands are often not. Local practice or policy circumstances, professional discretion, credibility. And by the way, some of these charts, if you need access to them, are in an article that Kurt Stange and I collaborated on, along with Russ Glasgow and David Atkins from the Agency for Healthcare Research and Quality. It's in the the American Journal of Preventive Medicine in 2009. This is another article where it appears. All right, so what is driving this squeeze of the evidence? My first candidate for consideration is the evidence-based medicine movement. Now, I'm a big fan of what it has done for medicine in pushing a lot of things off the table, practices that were traditional in medicine that had no place in a scientific world because they had been shown to be ineffectual. The evidence-based medicine movement has affected the publication priorities and peer review, the research synthesis processes of systematic reviews, guidelines and evidence-based practice inclusion, and it's even influenced the practitioners themselves. Now, I want to defend a little further evidence-based medicine because I want you to know, friends, colleagues, and countrymen, that I'm here to praise evidence, not to bury it. I believe passionately in the utility of evidence, but more passionately if it's done in ways that make it relevant and actionable and useful to practitioners. I don't want to be taking a drug that hasn't been through rigorous peer review from rigorous clinical trials. But as we talk about behavior change and community change and population change, we're dealing with a very different set of considerations, contextual factors. And here, the evidence-based medicine movement has become something of an albatross. We need to find different ways to view evidence and to treat it as a friend and not an enemy. Academic appointments, promotion, and tenure criteria are another bugaboo. They've been influenced by the evidence-based medicine movement. They influence peer review of grants, publication priorities, and peer review. And my last victim of ranting is the impact factor scoring. This has become the seal around all these other things, insofar as it makes the whole process of judging the value and the quality of research on the basis of the frequency with which it's cited. And this citation process is basically a measure of how much other scientists view it as valuable or relevant to their work. So it's a vicious circle that's created with the impact factor scoring insofar as it's really measuring academic impact. Scientific impact, perhaps, although one can argue against that too. And it has distorted a lot of the publication processes. I have sat on editorial boards where I've heard a discussion arise, particularly between the editor and the publisher, usually at the table, about how do we get our impact factor up on our journal. And some of the suggestions that come out, and I don't know how much they're implemented, are such things as, well, make sure that the manuscripts that we accept are ones that have cited other articles in our journal. I don't want to sound too cynical here, but it's a natural pursuit of excellence that you would want your journal to be highly cited, and one way to get there is to make sure that the authors, after review of their manuscripts, pay attention to other articles in your journal that they should have cited. So the impact factor scoring is influencing priorities. It's having a very notable impact on academic appointments and tenure, on publication priorities and peer review, and on peer review of grants. Now, when we don't see all of this evidence we've produced and sent up the pipeline, down the pipeline, I've characterized the pipeline as a funnel because of this squeezing process. We blame the practitioner, or we blame our failures of dissemination. Now, the practitioners are victims of this whole process, so this is a bad case of blaming the victim. Blaming dissemination has bothered me partly because when I look at what we have at our disposal for dissemination, I can see nothing but progress. Ever since smoke signals and fires, bonfires were used, and drums to communicate across great distances, we've done nothing but improve our ability to disseminate. The telegraph, the telephone, the radio, the television, and now all of the social media have done nothing but increase our ability to disseminate. If anything, people, as one author has said, I think it was the author of Future Shock, Nesbitt, I believe, we're drowning, let's see, we're drowning in information but starved for knowledge. So I think all of you can sympathize with the fact you get a lot more information than you need or certainly want, and sending more down those pipelines is probably not going to improve practice. So I'm a skeptic about dissemination being our first step forward. I think what we need to do is disseminate more strategically, more selectively, but not necessarily more voluminously. Another way of that the bridging problem has been conceptualized is by the U.S. agency that has responsibility for translation, the Agency for Healthcare Research and Quality. And Carolyn Clancy, who recently retired as director, presented this rendition of filling the gap or the chasm as seen by them and by an IOM committee. TRIP was their major initiative, translating research into practice, and it consisted of annual conferences and other devices by which they did a lot of dissemination. Diffusion, education, adoption, implementation, and innovation. Now, I kind of like this for its rendition of the set of variables that are at work here, and the squeezing of those that I think are less important and the broadening of those that I think are more important. Implementation and innovation, I think, are the bigger issues. Diffusion is, as I've already argued, lesser. But it is reminiscent for me of a concept that Stephen Polgar, an anthropologist, coined to describe the way that health educators were thinking about their job of communicating with the public in the first half of the century. There was this growing opportunity with the multiplication of mass media outlets to put information into the new media that were coming along. And what he said that it reflected was a mindset that was committing the fallacy of the empty vessel, that the people out there with whom we were trying to communicate were empty vessels, and if we just poured enough information into them, we would fill the vessel, and behavior, voila, would follow. So we are at risk, I think, of the same problem, and the vessel is probably overflowing in many respects. So we take that vessel and place it at the end of the pipeline, and what we see it's really filled with are all of these other considerations: funding, patient needs, demands, local practice circumstances, etc., etc. Well, here was the major initiative of the past few decades of NIH in trying to address the issue that Congress kept beating them over the head about. The NIH Roadmap Initiative, undertaken by Elias Zerhouni when he was appointed director of NIH in the early 90s. And what he said was that the roadmap identifies the most compelling opportunities in 3 arenas: new pathways to discovery, that's T1, research teams of the future, which was a recombination of people working together on T1, and re-engineering the clinical research enterprise, which is the clinical trials and eventually practice. But very little for the first decade was done on the practice end of this. Now, what we have with T2 is the roadmap less traveled, a term I borrowed from a colleague at UCSF. And we used it in the title of the article that I mentioned that Kurt Staney and I co-authored. And then came Jack Westphal at the University of Colorado, who coined the notion of blue highways on the NIH roadmap. You know, most roadmaps have red highways, those are the superhighways, and then they have blue roads, which are the back roads, right down to the driveways. And he suggested that T2 should be practice-based research. Phase 3 and Phase 4 clinical trials, observational studies, survey research, and that it would be cycled from and into practice and guideline development, meta-analysis, systematic reviews to translate it to patients. And then T3, he suggested, should be dissemination research and implementation research, translation to practice. Well, we've really done a lot of this work already. Canadian Task Force on Periodic Health Examination, which laid out methods for systematic reviews. The U.S. Preventive Services Task Force adopted their methods, and now the Task Force on Community Preventive Services has adopted them and adapted them to community trial issues and some of the external validity problems that I've been most concerned with. The Cochrane Collaboration, NICE, the United Kingdom initiative on systematic reviews and evidence-based guidelines. So all of that has helped to develop guidelines, and the Cochrane Collaboration has added a public health node to its networks. And then finally, we have program evaluation, continuous quality improvement, policy analysis, technical assistance in evidence-based practice, adaptation to systems, and systems research. All of that has been that's been the toolbox of things that we've brought to bear to try to get at the implementation issues and the gap between the evidence and implementation. Well, what survives through the pipeline is mostly randomized controlled trial evidence. It is the prevailing standard of evidence. Things don't get called evidence. They're not worthy of being considered evidence if they haven't been submitted to a randomized controlled trial, especially by government agencies that are looking for ways to say no to requests for funding of programs that haven't been submitted to carefully controlled, evidence-based trial efforts. So what we have is the context in which things are done. And with randomized controlled trials, we start with an intervention that's tested by comparison with a control condition. We usually have to declare our assumptions about mediating variables and sometimes moderating variables, but too often those are left unnamed because we usually try to control for them anyway. Though mediating variables in particular are the variables expected to change based on previous evidence and theory. We then expect that change to produce change in the outcome variables measured and compared between an experimental and control group or groups. Some of the problems with the first part of this is that the interventions are highly standardized. They need to be, or we wouldn't be able to describe what it is that we are testing. But in highly standardizing them, we've made it inappropriate, if not impossible, for practitioners who are doing the interventions to exercise any professional judgment about how it might be tweaked or appropriately adapted or modified to fit the patient in front of them or the community they're working with. Interventions tend to be reduced to rather simplistic forms because if they're too complex, we won't know what the operational ingredients of the intervention or program was. Everything else is held constant by randomization, and that's not a real-world reality. Clients are randomized, which means usually that they don't have a choice. They had a choice in being admitted to the study, submitting themselves to the study, but they had to sign an agreement, an informed agreement, that they may be in the experimental control or they may be in the control group, and they don't really have a choice in that. And in the reality of patient interaction with the system, they have a choice of usually more than one intervention, or at least accepting or not accepting the one intervention available. And the interventionists have no discretion. They are usually unrepresentative of the interventionists that will be using the intervention in the communities in which it will be sent ultimately. They're highly trained and highly supervised to assure that they don't deviate from the research protocol. And all of that produces unrepresentative, it produces problems in short of external validity. I'll come back to that concept presently. On the other side, the outcome side of this, the comparisons are based on average change for experimental and control groups. Now, average change is meaningful from a statistical perspective, but it ignores a lot of the variability. It takes the variability into account with standard deviations, but only mathematically. It's not really taken into consideration as to the people who did or didn't change in response to the intervention. And so we're very tempted to do subgroup analysis, but that has a history of falling into disrepute, most particularly in my review of this history, when the Mr. Fit trial, the multiple risk factor intervention trial, was undertaken in the late 70s, early 80s. Yeah, I think that was about right. And it got lackluster results. And so a lot of money had been spent on this. A lot of investigators in the multi-center trial were concerned about this unexpected result. So they started doing subgroup analyses to see who did and who didn't benefit from the interventions. And the statisticians threw up their hands, pulled out their hair, and said, you can't do that because the subgroups were not randomized. So you're comparing what might be apples and oranges. So subgroup analysis has fallen into disrepute, and it's awfully hard to get a manuscript published if you include it. Or it may get published, but the editor says this has got to go. Dropouts are discounted, even ignored, and the cutoff date for outcomes are often too soon for change to have occurred, especially if we're looking at behavior change. So all of those things are essentially ignoring, most of those things are essentially ignoring the context in which the study is done and the context in which the results might be applied and the differences between them and among them. So context disappears. Well, coming back. Let's bring it back. All right. In 2005, Philip Rothwell published an article in Lancet in which he had done some systematic interviews and investigation of why practitioners weren't applying evidence. And he concluded that the lack of consideration of external validity is the most frequent criticism by clinicians of randomized controlled trials, systematic reviews, and guidelines. Now, the practitioners didn't use the term external validity, but that's how he summed it up. And this is where Russell Glasgow and I took off on trying to take a hard look at how we can be sure that external validity is represented more thoroughly in the published literature. Now, CDC has long had the opportunity to do a lot more field testing of interventions because of its relationship with state and local health departments. So it has taken a slightly different pipeline notion from defining the problem to identifying the causes to developing and testing interventions, but also has increasingly engaged the practitioner community, the policymakers, the directors of agencies in a process of advising on the adaptation of the evidence, the adoption and widespread use. CDC also created the prevention research centers in the mid-'80s by an act of Congress, and 10 years later, Congress wanted a systematic study of how those prevention research centers were performing vis-a-vis their mandate. And they appointed an IOM committee, and this report is available to you, full text, readable online at this website, and all you need is the first part of the web address, the link, nap.iom.edu. I think that got left out. nap.edu is what it should say. And then you can click on review of prevention research centers or anything like that, and this will come up, and you can go into this report, and what you'll find is that this committee, and I am responsible as having chaired this committee, so I'll take responsibility for misrepresenting it now. This report essentially said that what's happened with the first 10 years of these prevention research centers is that they've undertaken a very academic form of research. That is, you've got a lot of academics sitting in the schools of public health that receive these awards, and they are pursuing their pet projects at their desks, in their schools of public health, in their universities. And what the committee recommended was that CDC undertake a more systematic emphasis on community engagement. So the next round of funding for prevention research centers sought to get the prevention research centers to do a lot more community-based participatory research. Now, we didn't say in the report that it had to be community-based. It needed to be community-engaged. It needed to be community-informed. But community-based participatory research was coming along as a new movement in the research arena in the mid-90s, and so it really became the tool that CDC imposed on the next round of funding for prevention research centers. Well, part of the reason for the problem that we observed in the schools of public health was a psychological bias in the social research on public health. The schools of public health began hiring behavioral scientists in the 60s and 70s, and at that time the ones mostly available were psychologists, unemployed, recently minted PhDs in psychology who came into the schools of public health and immediately started testing their theories from their dissertation research, and much of it was focused on individual behavior. So there, in the 50s, when the rising death rates from chronic diseases crossed the declining rates from communicable diseases, we were suddenly faced with the need for a much better understanding of behavior. The early health education and behavioral science pioneers in schools of public health were engaged in that fallacy of the empty vessel that I described earlier. And the first waves of new faculty as schools of public health, medicine, dentistry, nursing, and NIH all built up their social behavioral sciences were mostly from the psychological fields. They were multiple. What the psychologists themselves, in going back and reviewing their literature most recently, have found is that what's good for scientists is not necessarily good for science. Leveraging by chance, the studies they reviewed had tended to leverage chance by running many low-powered studies rather than a few high-powered studies, power being related to sample size, as you know. Uncritically dismissing failed studies as pilot tests or because of methodological flaws, but uncritically accepting successful studies as methodologically sound. Selectively reporting studies with positive results and not studies with negative results. Or selectively reporting clean results, that is, waiting until you had cleaned out all of the aberrations in the data. Stopping data collection as soon as the intended effect was obtained. And this is one that's really worried me about the trials on which we are now circumcising adult males in Africa on the basis of 3 studies, all of which were terminated before we could possibly know the consequences for the spouses of the circumcised men and their subsequent behavior on the assumption that they were protected. And I'm afraid it's a public health disaster waiting to happen, but don't get me started. Stopping data collection as soon as intended effect is obtained, resting on internal validity without much concern for external validity. And this is where Kurt Stengy and Gus Glasgow and I have all collaborated to try to get more attention to the external validity problem. So we've been through these eras of behavioral research and development. I don't think I'll belabor them here. I'm leaving a copy of this, and they're recording this so you can access all of this. If you will contact Elaine or Sue, one of them. 3 other IOM reports most recently have really tried to grapple with the bridging the evidence gap issue, and particularly in relation to obesity prevention. This one, published in 2010, concluded that much of the evidence has a narrow focus. It lacks attention to larger systems contexts. Much of it is lacking detail of the implementation process. That's the first thing that editors seem to want to start slicing away when the manuscript is too long, is rich detail about the intervention. Well, that's the stuff that practitioners most need to be able to read the detail about if they're going to implement it. Much of it lacks relevance to the real world. That seems a little gratuitous. Many studies focus on one intervention, but obesity may require a combination of interventions. In fact, some things appear not to work when tested alone, but are essential ingredients in a more comprehensive program. So it's a bit of a paradox. We find that some interventions don't work by themselves, but we can't do without them in a larger, complex, comprehensive program. The current evidence lacks the power to set a clear direction for obesity prevention across a range of target populations, because most of it is done in one place under highly controlled conditions. This lack of evidence for effectiveness is seen as a lack of effectiveness. Practitioners say, well, if we don't have much evidence of effectiveness, we must assume that this is not effective. Well, the opposite conclusion might be just as warranted. It's difficult to fund, conduct, and publish research on community, environmental, and policy-based obesity prevention initiatives. Assessing or reporting on generalizability of research results to other populations or settings has not been given priority. Now, the Task Force on Community Preventive Services has really undertaken much more attention to this last one in its systematic reviews of the literature on community. So this IOM committee developed the LEAD framework for a more inclusive evidence base. LEAD was locate evidence, evaluate evidence, assemble evidence, and inform decisions. And it was very ecumenical in its inclusion of what qualifies as evidence. The next IOM committee that grappled with some of this is one on an integrated framework for assessing the value of community-based prevention. So, groping through many hundreds, really, of models that are out there, the committee came to a few that it found helpful in coming to the questions asked by the sponsors of this study. And one of them was the precede-proceed model. And what they were particularly interested in was the phase one, the social inquiry process that should precede the epidemiological diagnosis. And because this committee was heavily weighted with economists, and they wanted attention to the ultimate costs and benefits in dollar terms of the outcome. So it wasn't quality of life so much that they were concerned with, but the social benefit as measured by economic balancing. The next report was the Evaluating Obesity Prevention Efforts. This one has just been published last month and is now online for your bathtub reading. What this committee tried to do was to scan the several hundred indicators that are out there to assess their quality, their availability, their consistency of measurement, and a variety of other considerations. And we boiled it down to 82 indicators that have become the measures we carry forward to recommend to the federal government what it needs to do, to state governments on what they need to do, and to ways in which local governments and agencies concerned with obesity control can adapt these measures for their local purposes, even when they're not contained in local surveys. And most of the national data surveillance systems don't go down to the local level. They're national and they're state, but they're not local. Types of community-engaged evidence for health research then include participatory research, surveillance evidence, population diagnostic evidence, and program evaluation evidence. All of these have some degree of community engagement and some degree of practitioner engagement, and therefore, I think worthy of more attention in building the evidence-based, a practice-based evidence base. Spheres of practice-based, community-based, and academic participatory research are all overlapping with each other. Something like this. And I carry no brief for any one of these being superior to others, but I think a blending of them is what we need as we go forward. Now, there are three paradoxes that all of this poses, and I'm going to quit soon because I want to hear your sources of confusion here. The internal validity, external validity paradox. The more rigorously controlled a study testing the efficacy of an intervention, the less reality-based it may become, so it cannot be taken to scale or generalized with assurance of applicability. The specificity generalizability paradox. The more relevant and particular to the local context, the less generalizable it may be to other contexts. So I think the only remedy for these is multi-site trials where we can look for the important community variables that may account for more or less success. And then there's another one. I think I won't go into this one because it takes us in another direction. Publications on community-based participatory research have skyrocketed. These are the journals that publish most of what was done up to 2011. The case that I think is most compelling for participatory research is that we view the world through different lenses. Professionals and scientists view it through lenses that have high visual acuity on the objective indicators of health. The public and the lay people have lenses that are more diffuse, but certainly more acute on the subjective indicators. Now, I think our tendency is to say, well, the objective indicators are inherently more important. Well, when you think about behavior change, in reality, the most important is going to be subjective indicators, subjective perceptions of health. So I think we need to be sure that we're balancing those perspectives on the world, and here's one way to view that. We have with our objective lenses, a concept of what are the actual needs of the community. We measure them objectively. People and some practitioners perceive needs and priorities that aren't measured, or if they are, they're not measured representatively or diffusely. So their view is a little different. And policymakers have a view of resources, issues of feasibility, and policy harmony. So it is in the area of overlap among these, A, where we have the greatest potential for action. So what we want to do is enlarge area A. And we do that in part bringing the eastern and the western spheres closer together and the southern sphere further north to enlarge the area of action. We move people's perceived needs and priorities toward our view of actual needs through public health education in particular. We move our perception further west through participatory research. And we try to get the policymakers to see it our way and the way of the public through advocacy for regulation and organizational development. And there are subspecies here of policy research and surveillance that combine these in various ways. Well, I think that that brings me to this conclusion. If we want more evidence-based practice, we need more practice-based evidence. My compliments to your colleagues here at Case Western Reserve University for the excellent work they're doing through the Prevention Research Center, and particularly and the Department of Family Medicine and Community Health. The work with community groups is exemplary from what I've observed over the last 2 days, and I wish you well in continuing in that work. Thank you very much. So let us have some cross-examination of the witness here. I should have prompted you 3 slides ago to get ready with your questions. Stunned silence. Yes, ma'am.
What suggestions would you have for graduate students who are undertaking research, whether it's a capstone or a thesis, who aren't necessarily getting funding from anyone, but it's part of their curriculum, to promote practice-based research without all the resources?
Well, I'm going to give you a one-liner on this, but I realize that it's got some traps in it. The one-liner is get out there and view reality firsthand. Don't just depend on the published literature. You need to see these things happening in real time with real people in real places. And the most thorough way to do that, here come the traps, is community-based participatory research, or at least participatory research with practitioners or policymakers, program planners. And the trap then is the labor intensity of that, the time consumption. And if you're on a student clock or a tenure clock as an assistant professor, you may be committing some form of academic suicide. So, do what you can, but be careful not to get sucked into responsibilities in the community for which you don't have resources or time. And try to keep as much as possible in your first outings in an observer role rather than a doer role. Thanks for that question. Yes, Dr. Frank.
One of the dilemmas we have in public health is what in fact is meant by practice. In clinical medicine, it's quite obvious what practice is, but how different people perceive public health practice varies greatly, and it's a part result of our public health system. So I would view public health practice primarily as local health department based, and someone else might view it in a very different way.
Yeah. Well, I think once again, we really have no choice but to be pretty ecumenical about this in public health, because especially if we accept the proposition that we need to engage the community, because then the community become co-practitioners. And the members of advisory boards and the people who take initiative in participatory research warrant recognition as having learned some of our skills, having applied some of our knowledge, and needing to be recognized for that. Now, clearly the MPH degree is the union card, but a lot of public health gets done by people without MPH degrees. So I think my bottom line is ecumenicalism. Yes, sir.
You mentioned earlier the importance of inter-site research to avoid the hothouse environment. And I wondered if you could maybe say a few more things about what you meant by that.
The idea is pretty simple, but it gets complex if you want to be committed also to a participatory approach to it. So you can have multi-site studies, and we have a lot of them sponsored by NIH, where you have multi-center studies with a principal investigator at each site, but they have to agree on a protocol, and that protocol has to be implemented with fidelity, with all of its moral overtones. And so you end up with interventions, as with the COMMIT trial most famously, that are imposed on 26 communities uniformly, regardless of the variations in those communities. I was talking with Elaine and her colleagues about the history of the commit trial and how one of the communities was a Canadian community. Well, they were working under very different circumstances, but they couldn't budge from the protocol because they were under contract, essentially, to implement the protocol as written in Washington, or Bethesda. So what David Katz and several others of us have written in the American Journal of Public Health about 2 years ago, I think now, is a proposal for a community-based participatory research overlay on multi-center trials. That is, you've got some common elements in the interventions that are going to be tested, but you allow the communities to adapt them to their settings and their population, the variations among them. And that will produce, we think, a more robust conclusion about whether it works, with whom is it most likely to work, where doesn't it work, and with what adaptations will it work better or worse. Does that help?
Thank you.
Pleasure. Thank you. Dr. Stengi.
What do you see as the opportunities for developing infrastructure to assess some of the natural experiments you mentioned?
Well, that's precisely what this last IOM report that I showed the cover of is attempting to address, is how can we make these surveillance systems in particular, but also the monitoring of implementation of funded grants, how can we make them more consistent in the measurement so that we can make comparisons across communities, across settings? And I think if the set of recommendations we made, particularly at least in the first instance to the federal government for coordination among agencies to harmonize their measurements of the same thing, measured differently by different agencies, we would go a long way toward assuring that we have comparability across jurisdictions. But coordination is an unnatural act in the federal government, apparently. Elaine, Dr. Borowski.
The indicators part of this. So when you think of, we were talking about last time, like what do you put some things out there as sort of the ticket we want to grab for. You know, what's your best thoughts about what are those elements? I mean, are they, you know, we for a long time have been very chronic disease oriented. You know, are we looking for a 5% reduction in something specific? Or is there some new conceptualization about a combination of, I think of your circles, right? You know, so some of those actual needs, maybe more of those objective. But how do we come to sort of a set of indicators that resonate with a lot of different people, but still is sort of the way in which to say, did you move the needle on these?
Yeah. Well, what the evaluation committee, the IOM Committee on Evaluation of Obesity concluded was that we need to appeal particularly to the healthy people objectives, the objectives for the nation, because there has been a lot of consensus work that went into those, and a lot of scientific massaging of what we know and what we don't know, and what we can reasonably assume based on extrapolations and so forth. So that's our touchstone. And those objectives then become the goals that all of us could reasonably be shooting for. Now they are stretch goals. They are goals that are not going to be easy to reach in many, if not most, jurisdictions. So they're a challenge, but I think that's what we need, is a challenge. So I would refer you particularly to the Healthy People 2020 objectives. And they, by the way, have been most decidedly textured this time around. You know, they've been around for several decades. Each decade they get more robust in one sense or another. But this time the Assistant Secretary of Health, Howard Koh, made a particular point of insisting that they be based as much as possible on a social determinants of health perspective. So they are less strictly health department or health agency objectives. They are now more community objectives in which cooperation will be needed across agencies. Thank you, Elaine. I think I have tried your patience. Was there one more you were pointing to, Kathy? Oh, yes.
I'm curious your thoughts about two sort of big new streams of data that I think are coming into the conversation. One is big data that's being leveraged, say, out of Twitter feeds or Google searches. And the other is sort of consumer-generated data that people are putting into their apps where they're logging their food and activity. How do you see that playing out into evidence?
Well, so far the apps are not proving to be very effective in changing complex behaviors like weight control. But they certainly show promise. And the problem is that with the current funding structure, you apply for a grant as you see a new app developed. You get the grant maybe 2 years later, and that app no longer exists. Another innovation has come along, and so people have presented this, have represented this sequence. I think an article that you and Russ did, Dr. Stengi, showed a continuum of the life history of communication innovations and the life history of grants and grant applications, and they're not well matched. So we're going to have a hard time evaluating those on the NIH timetable. But I think that when they disappear, it's often because they didn't work as intended. Okay, well, thank you all very, very much. I've been really enjoying this.